Right now, more than 90% of Americans have healthcare coverage. Let's build on that. Blue Cross and Blue Shield companies are committed to closing the gap by expanding access to coverage, addressing disparities, and removing barriers to care. Because we believe everyone should have access to care, no matter who you are or where you live. Let's build on what's working for the health of America.
Hi, everyone. Welcome, and thank you for joining us today. I'm Justine Handelman, Senior Vice President at the Blue Cross Blue Shield Association. For generations, people of color have experienced the U.S. health system differently than white people. Institutional bias and systemic racism have led to drastic and worsening disparities and inequities. We are working to identify and address this ongoing crisis and change the trajectory, creating a more equitable healthcare system, which is why we recently launched a multi-year national health equity strategy. This strategy will focus on numerous conditions that disproportionately impact communities of color, including maternal health, behavioral health, diabetes, and cardiovascular disease. Today, we have an exciting panel of experts that's ready to dive into this very important topic. But first, it's my pleasure to welcome Sean Robbins, the new Executive Vice President of External Affairs at the Blue Cross Blue Shield Association. Thanks for joining us today, Sean.
Thanks, Justine. I'm really glad to be here with you and everyone else that's attending. And I just want to start by saying thank you to the audience, all of you that are here, for your commitment. Now, Congress and the administration are taking real steps towards a more equitable healthcare system, and so are we. And everyone that's gathered here likely knows the CDC recently declared racism as a serious public health threat. And for those of us in healthcare every day on the ground, we understand how serious the consequences can be for continuing on the path that we're on. As this group knows probably all too well, compared to other high-income countries, maternal health outcomes in the United States are very poor, behind what we deserve. But for women of color, particularly Black and Native women, outcomes are even worse. Their likelihood of dying from pregnancy-related complications is up to 3 times that of white women. And delivery complications are 46% higher among Black women, irrespective of income and education level. In fact, a Blue Cross Blue Shield Health of America report released just last week showed that race had a greater impact on pregnancy complications than age, which is why the Blue Cross and Blue Shield companies across the country are committed to reducing racial disparities in maternal health by 50% in the next 5 years. To do this, along with all of our 35 Blue plans around the country, we are scaling programs from local companies proven to improve equity, creating standardized national measures. We can't fix what we don't measure. Blue Cross and Blue Shield companies across the country are already engaged in interventions, such as identifying pregnant women with high-risk conditions early on and providing them with one-on-one support, addressing food insecurity among pregnant women, and improving prenatal nutrition. We're also connecting providers with implicit bias training. As you'll hear from our panelists, in Michigan alone, we're already reaching 20,000 providers. And we know there's more work to be done. Importantly, we're not doing it alone. We're relying on close collaboration with our healthcare providers, community leaders, and advocates. These issues, these disparities did not occur overnight, and they're not going to be fixed overnight. They're a result of ongoing bias and systematic racism. But together, we can improve our healthcare system to ensure all Americans have the access and the care that they need. This country deserves it. So with that, thank you all for tuning in today, for joining us on this journey. And I'd like to turn things back over to Justine as she welcomes our esteemed panel. Thanks, Justine.
Great, thank you, Sean. It is my pleasure now to welcome our esteemed panel. We have Bridget Hurd, Vice President of Diversity and Inclusion at Blue Cross Blue Shield of Michigan. Dr. Deborah Smith, Medical Director at the Blue Cross Blue Shield Association, and Dr. Rahul Gupta, Senior Vice President and Chief Medical and Health Officer at the March of Dimes. So thank you all for being here today. Let me just start off. We know racial health disparities exist, and we know they can have dire consequences on health. How did we get here?
Yes, I'll go ahead and take the lead on this question. And it's such a great question to ask. And I really think it builds the foundation for truly understanding how to address these issues. I always think about health and healthcare disparities because it changes the way we think about solutions. Health disparities refer to that focus on differences in health outcomes, whether it's morbidity or mortality. But then we also have to think about health care disparities. And that really takes us to the place of looking at things like the quality of care that's delivered, the access to care, and understanding and be able to leverage barriers and remove those barriers that might get in the way to access. So we know 2020 was a year like we've never experienced before, and that the spotlight was on this thing called health disparities. But has already been mentioned, health disparities are not new. They've been around a very, very long time. So when we look back, and we can look back actually over hundreds of years in terms of bias, systemic racism, and discrimination that has occurred. We can look at things about how enslaved women, for example, were treated as part of gynecological exams and experiments, actually, without anesthesia. And of course, we know the Tuskegee syphilis experiment and the impact that had on African-American communities. And these actions have created prevailing perceptions that have, interestingly enough, been passed on from generation to generation, where research shows that there are beliefs that still sustain today that, for example, African-Americans have a different pain tolerance. And that's still in practice today, those beliefs still exist. Or we can think about just the whole notion of how Blacks or women, Native Americans, Hispanic, Latino, how they are deserving of care. So coupled with that also is the ideal or the lack of cultural competency. That means having providers that can adjust or adapt to the person that is in front of them. So those also become a driver of some of the health outcomes and some of the disparities that we see in healthcare delivery. So we have all become familiar with the terminology social determinants of health or social drivers of health. And it can be factors like stress that results from living conditions or the unconscious bias that many experience in the provider office, for example. And I always have to pause and say, when we think about bias, we must remember that as human beings, we all have bias. And the key is developing that understanding and that awareness so that we can mitigate that bias in, patient-provider care, for example. And we can look at socioeconomic status. So there are many, many contributors. And I'll add one more thing. When we think specifically about maternal health, we have heard the stories and on a national level of celebrities, even like Serena Williams, who talked about how her calls for action about what she was experiencing as part of her maternal birthing experience, how they were just ignored. And we hear that story over and over again. So when we think about how we got to this place, it's not the straight line to answering that question. There are many, many factors that are involved, but we have to consider all of them when we're developing solutions.
That is so true. And, I really want to first of all start out with it's commending really the Blue Cross Blue Shield Association for putting this together, and my panelists, of course, because this is an issue that is so critical at this time and juncture in our nation's history to talk about, because we really think, moms and babies are, for any civil society, the cornerstone of that civilization and defines that civilization. So first of all, I want to start out with a positive, which is, in the United States today, it is possible for every mom and baby to have a positive health outcome. However, we've got to start from there and understand that's not the case. Why is that not the case? As you've said, Bridget, as well as Sean has highlighted, that we are amongst one of the most dangerous developed nations on the globe to give birth. We know that every 12 hours, around the clock, a woman dies as a consequence of pregnancy and childbirth complications. And that's two babies every hour are dying before they reach first year. Now, the causes, as we are discussing here today, in our nation's maternal and infant health crisis are complex. They include physical health, mental health, aspects of social determinants, as been very well highlighted, and many, many other things. They can be traced back to issues in our healthcare system, such as the quality of care, systemic problems, implicit bias, but they also stem from factors in our homes, in our workplaces, in our communities, factors such as we discussed, and we're going to discuss more about structural racism as an underlying layer fueling the health equity gap. We also think there are inequitable conditions. For example, unequal access to housing, transportation, neighborhood safety. Pandemic has really unveiled the impact of a person's ability to achieve good health, even starting at birth. And then there are direct causes of sickness and death, such as cardiovascular conditions, hypertension, hemorrhage infections, all of those which are disproportionately impacting Black and brown populations. And a variety of these factors impact mom and baby health. We still have a lot to learn. So it's important that we understand that these factors are intertwined. And addressing maternal health factors, especially prior to pregnancy, increases the chances of a healthy full-time birth. So what does that mean is that pregnancy is a situation oftentimes where we have to work before the condition of work happens as pregnancy. So pre-pregnancy conditions such as high blood pressure, diabetes, and obesity are each increasing every year in the United States. And we know that the Black and brown populations are often disproportionately impacted as opposed to whites for these conditions. So we have to recognize that along with structural racism that does exist in our society, also exists the same racism in healthcare system. And there's nothing about a Black or brown woman that makes her more likely to die after childbirth or have poor birth outcomes or not breastfeed. It's something around the environment that she lives in, the care that she's receiving, the access to services, and how she is literally treated during pregnancy, because of which we have this crisis and we need to be addressing all these complex intricacies within our system.
So let me just talk for a moment about our research. I know Sean mentioned our Health of America report, and it shows across all age groups the rate of severe maternal morbidity, or what we call SMM, unexpected outcomes of labor and delivery resulting in significant health consequences, is higher for Black and Hispanic communities compared to white ones. SMM rates are 63% higher for women in majority Black communities and 32% higher for women in majority Hispanic communities when compared to majority white communities. In addition, compared to white women, Black and Hispanic women reported feeling less confident that they would receive the care they need. And fewer Black and Hispanic mothers, 62% and 71%, complete all the recommended prenatal care compared to 82% of white women. So what are the long-term consequences for both the mother and the baby?
So I think, again, as we mentioned the SMM and we talk about mortality and morbidity, I think our audiences are probably thinking, what is all these numbers, right? But numbers are important because, as Sean mentioned, if we are not measuring, we're not responding and reacting and improving. So it's critical that these values are actually mean lives to people. And these numbers are important because, these rates of pre-pregnancy high blood pressure or these rates of high diabetes are directly correlate with poor outcomes. And we unfortunately, these numbers are very similar to what we're finding at March Times. At the bottom line here is, whether it's the inadequate prenatal care, which is in African American women more than twice the rate among white women, or it's the inadequacy care during pregnancy with all those factors we mentioned, there is a reason that we need to be thinking about a comprehensive solution, a way to address where health and healthcare is given in a way or discharged in a way that is fair to people, that is just to people, and it results in good outcomes. So I think these numbers are highlighting and really begin to unveil the disproportionate amount of health that occurs within our societies. And if we are to achieve equity in health and healthcare, it's critical that we start to look at where we're failing, which is a number of places, as you mentioned, Justine, and we begin to address each one of these areas. So it's really critical, but the research that you've highlighted is very much in line with other national research, including that of the March Times. I'll turn it over to Dr. Smith as well.
Dr. Smith?
I think I got reconnected. I'm sorry if I missed some of Dr. Gupta's comments, but I think as we were talking about the explicit disparities issues that were elucidated in our Health of America report, one of the things that I wanted to focus on was what are some of the longer term consequences of the severe maternal morbidity. I hope I'm not repeating some things which logically Dr. Gupta may have spoken to. When we think about severe maternal morbidity, we're describing unintended outcomes in labor and delivery and the birthing time period that result in significant short and long-term consequences. I previously practiced obstetrics for over 2 decades and was involved in health teams, professional training. So I would want to emphasize that in many instances, unintended should not be interpreted as unexpected or not preventable. So let's use as an example severe preeclampsia, one of the high blood pressure disorders unique to pregnancy, where disparities were identified in our Maternal Health of America report. So women who experience preeclampsia are at risk of future chronic high blood pressure, chronic hypertension when not pregnant. And in the most severe cases, they may actually suffer reduction in their kidney function. These conditions mean that one of the most important improvement opportunities that we have in our care is the provision of extended care into the postpartum period, where we can manage these longer term consequences for the long-term benefit of a woman's health and indeed in preparation possibly for a subsequent pregnancy. In this condition called preeclampsia, the function of the placenta may also be impacted such that the infant may not grow well and results in a low birth weight baby. And these infants are also at greater risk of developing high blood pressure and other conditions, chronic conditions, as they become adults. A number of folks have already spoken to this idea of stress. And as much as I've just described a couple of physical condition outcomes, it is perhaps equally important, if not more important, to speak to the outcomes of the psychosocial outcomes that occur when an adverse event has occurred for a birthing person. And so the psychosocial stress after these problem outcomes also may impact the family dynamics and the family at large. And this is a place where, in addition to looking at the root causes of perhaps things that need to be improved in our clinical care, we need to do that evaluation as to whether or not bias and discrimination has actually played a role, particularly for women of color, in these adverse outcomes, and to be able to process that both for an individual and their family, as well as for a community that may be impacted. I remember a long time ago, one of my patients, when I was doing an OB exam, and everybody knows about measuring the belly for growth, and asked me, was I measuring and outlining the place where I was going to do the C-section? And so this was because the community experience, the neighborhood experience, was that many women ended up with cesarean sections, and that potential complication in pregnancy, and therefore this was being anticipated. So we need to understand that for women of color in particular, that there may be stresses that are not appreciated about the prenatal and the labor and delivery experience.
Thank you for that. That was very helpful. I have a couple more questions, and I want to just say to those participants in our audience, feel free to put questions in the chat. We are going to want to hear from you and answer your questions as well. But Blue Cross Blue Shield companies, they've made a commitment to working with partners in local communities to reduce racial health disparities by 50% over the next 5 years. What are some of the proven interventions you've seen in your own communities, and what next steps can be taken to further reduce disparities?
Yeah, so I would like to take the opportunity to respond representing Blue Cross Blue Shield of Michigan. When we think about addressing health and healthcare disparities, it really is a partnership. It's a community effort. There's no one entity that can do it alone. And when we think about that concept of health equity, creating that environment where an individual can achieve what we call optimal health, is really that mix of community partners and stakeholders coming together. When we think about the long-term consequences, the importance of being able to provide support systems for individuals in our communities, but also being able to address those drivers of healthcare, those become very important. Whether it is facilitating transportation to prenatal care visits, providing partnerships to enable mothers or individuals who are pregnant to make sure they're getting those exams, that prenatal care in their first trimester, so we don't see some of the negative consequences of waiting into the third trimester, for example, for care. So those are just some examples. One thing that we're looking at as well, we have an obstetrics initiative. It's a collaborative quality initiative that is in place across the state of Michigan. Blue Cross Blue Shield Michigan is the primary supporter of this. And it looks at the rate of C-sections, how they occur, and make sure that they're occurring for the right reasons. We are also looking at opportunities to develop programming that focuses on identifying high-risk maternity members and conducting outreach to them to specifically ask them questions, to help them understand the necessity of early prenatal care, to provide support that first week after pregnancy and moving throughout the time postpartum. That's another example. We're looking at ways where we can look at different functions of different clinical settings to provide a distinction in terms of their level of care and following those best practice protocols. So that's another opportunity that we're looking at. But what we've been most excited for over these last several months has been our focus on unconscious bias education. And I do use the word education. I'm big on terminology because when we training, we use that terminology, we think, oh, I got to go to this training, I got to check it off. But when we're receiving education, it translates in the wiring of our minds as something that I need to invest in. It's an investment in my growth and my development. So we have launched, and starting in September of last year, our unconscious bias education program, starting with our primary care providers and then moving through the specialists as well, to really create that awareness and understanding that, again, as human beings, we are all wired to have bias, but most importantly, to understand how the research indicates that bias shows up in healthcare delivery, and that it's something that we need to be aware of, and that we need to take intentional and deliberate actions to mitigate that. So in our first round, as we're calling our first phase, we're reaching about 4,600 primary care physicians. And good news also for the state of Michigan, there's an executive mandate that requires unconscious bias education as part of the licensure. And we just received approval for those recommendations just last week. And then we will continue to be able to build on what we're doing in partnership with the state of Michigan to reach those 20,000 providers, and again, inform them on what to look out for in patient-provider interactions, for example. And so those are just some examples of what we can do as a health plan. But I'm going to reemphasize, it's those partnerships not only with the providers, but with community organizations. So we are providing the appropriate support systems that make a difference on this journey through the maternity process.
And I will mention that too. And I'll just start with, as Bridget mentioned, really, to have biases to be human. So it's actually a natural process and part of our evolution as human beings. Is what's allowed us to survive through this whole process and stay alive, really. Where it's not worthy and it's not supposed to be is obviously work, decision, judgments, daily life, and one has to do and actively work to manage our biases. So I want to talk about a little bit about the March Times implicit bias training and the great work and our partnership with the Blue Cross Blue Shield Association, but also some of the other innovative care models that I think are important to discuss as this is a complex issue, and it would be important for us to think about how do we address a complex issue with best evidence-based models. So we clearly understand that implicit bias trainings are important. However, implicit bias trainings in medical settings is a way to prevent suffering and save lives. We need to dive into the uncomfortable conversations and hard issues because that's exactly how change happens. But let's be very clear. Implicit bias trainings alone is not enough. We all here are doing our part, but there is neither sufficient data nor enough investments in what is scalable. So it's very important for us to engage on these issues with sensitivity and care. That is what training does for implicit bias. But more importantly, we need to be ensuring that every American who enters a medical setting is cared for solely based on the diagnosis and not harmed because of the color of their skin. Now, if we use that as the endpoint and begin to work back, there's a lot of work that needs to be done. So one of the things we're doing is with Blue Cross Blue Shield Association, as well as March Times, has launched an implicit bias training for healthcare providers and have trained, thousands of healthcare professionals. But it's also important to understand that the core is improving patient-provider communications and treatment decisions, as well as the quality of care at a critical intervention point. So let me talk a little bit about some of the innovative models of care, maybe 2 or 3 that I think is going to be important for us as we move forward from both a policy as well as a practice standpoint. There's something called group prenatal care. March Times has a version called supportive pregnancy care of that. We know that group prenatal care is the notion of bringing a small cohort of pregnant women, almost about the same with similar due dates to participate in structured prenatal care program, which is facilitated by a clinician and a facilitator. Now, good studies have shown that this type of an intervention can reduce preterm birth by as much as 33%. Think about this. This is basically a group care model, reducing preterm birth by 33%. And guess what? If you look at the Black women who participated in group prenatal care, there's a 41% reduction in preterm birth. So we know that there are interventions with evidence that are able to reduce both not just preterm birth, but the ensuing healthcare costs. And they really improve the psychological outcomes for pregnant people, as well as improving the readiness for labor and delivery compared with traditional prenatal care. So traditional prenatal care versus newer models like this is important. Now, many of these programs that discharge this type of care often rely on grant funding or state or federal resources to initiate and implement this type of care. So it's important that those states that have been successful, actually that's where the state Medicaid agency and the Medicaid managed care organizations, or MCO, have worked together to ensure the existence of an enhanced reimbursement program, regardless of the payer. So it's important that these types of supportive pregnancy care type of models across the nation allow women to take charge of their own care, placing that power back into the hands of moms and families who often face more barriers than support. This is one type of program that we're training healthcare providers across the nation, as well as individuals and patients, to communicate better, to recognize biases, and improve the way healthcare is discharged. The second one I want to talk about very quickly is doula care. Doula care has been in evidence and literature associated with improved outcomes for moms and infants, including amongst communities experiencing disproportionate amount of high rate support outcomes. So there's a study that showed that 39% of non-Hispanic Black mothers and 30% of Hispanic respondents said that they did not use doula, and they would have liked to have doula care. So we again have a sort of imbalance in our society where we have evidence-based practice and workforce expansion needs, yet the equitable, culturally competent doula care does not exist for too many women. So it's important that doulas' inclusion of that from a racially and ethnically, socioeconomically and culturally diverse communities standpoint becomes critical. It will improve care at the end of the day. It's also think about, we conducted a study in March Dimes showing these what they call maternity care deserts. So the challenge is that we know that there exists almost half of the counties in the United States are somewhat or fully a maternity care desert, with limited access to maternity care. And that's responsible for about 7 million women of childbearing age. 1 in 8 babies are born in these areas. And there's a disproportionate representation of women of color. So the question then becomes, what do we do about that? So it's not just the workforce aspect, the doulas and midwives are important, but also the issue of broadband and telehealth. We know that technology can play a critical role in improving health equity with geographical access to broadband services and affordable access for all levels of socioeconomics. So it's very important that as we discuss and talk about telehealth and broadband, we once again, do not leave behind the population that are already suffering from a disproportionate access and disproportionate service level and racism on top of that.
I'd like to really speak to some things that we're doing at the association level to try to gather up all of these ideas, right? These models and that have been spoken to. Because we do have this extremely aspirational and bold goal for reduction of disparities in maternal health by 50%. And I like to put that, bring that down to another level that I think creates the opportunity for really meaningful change. And that is that our overall goal is to provide trustworthy and respectful evidence-based care. So in order to implement the National Health Equity Strategy with respect to maternal health, the association is acting with a lot of C's, as I like to say. We're acting as a convener, a collaborator, a collator, and a communicator around all of the issues as well as the solutions involving all of our plans. So right now, the office that I belong to, the Office of Clinical Affairs, along with multiple other association swim lanes, as I like to call them, are currently involved in an inventory of all of the efforts that plans are already making to improve maternal health. We're assessing those programs that are using an explicit health equity lens, those that are at the stage of embracing the challenge, and those with programs of special significance, such as, for example, expanding the use of virtual care. And our goal is to facilitate cross-plan learning interactions, share lessons, and result in meaningful change. And we're doing this with feedback from our National Advisory Council partners, including, of course, the March of Dimes.
Great, thank you. And I do see we have some questions coming in the Q&A. So again, remind folks, if you have a question, you can put it there. Let me just shift gears a little bit. BCBSA strongly supports the Black Maternal Health Caucus Momnibus. It's a package of 11 bills aimed at improving the health outcomes of pregnant women and mothers, particularly African American and Native American women, incarcerated women, female veterans, and others. So what advice would you have for federal lawmakers working to improve equity in women's health?
Thank you, Justine. I think that's a great question, and I'll just start on this. I think when we look at, we began our conversation with talking about how complex this issue is. If it was simple, we would have solved it already. And I think it's, when we say complex, it's kind of a code word for, it's going to need all hands on deck approach. Every one of us has a role to play, but it's very important that we understand the complexities, but also the challenges that come in. So to be simply and frank about this, I think it's going to be important that we have policies and legislation that look at making critical investments in social determinants of health that influence maternal health outcomes like housing and transportation and nutrition. But then it doesn't end there. We have to also think about how do we improve maternal health outcomes and promote equity and implicit bias trainings and ensure that racism gets to begin to become rooted out of the system of healthcare, where maternal infant health could be used as a model example for other areas of healthcare to root out. After, National Academy of Sciences mentioned racism as an important part of a problem in healthcare system back in 2002. But then it doesn't end there. We also have to look at and protect our veterans. We also have to look at the perinatal workforce that we talked about. We have to look at the data and solutions to address and to develop comprehensive real-time solutions from a data aspect and adhere to technology, including broadband. But it doesn't end there. We also have to look at the mental health condition and substance use disorders during the time of pregnancy, pre and post. We also have to look at the entire continuum of pregnancy as well as the postpartum aspect and coverage and access for that. And it still doesn't end there because there are incarcerated moms and to-be moms that we must look at. We also have to look at making sure that the high quality of maternity care and continuity of insurance coverage is provided, not just for the infant after birth, but also for the mother for at least 12 months after the birth of the baby. And then we have to think about also how does this relate back to the levels of exposure to climate change related risks for moms and babies. We also have to look at the importance of maternal vaccinations in order to help protect the health and safety of moms and babies. So if you start to look at it, it's not one thing that we look at. It's a compendium of all of these long time neglected issues that we have to bring into comprehensive piece as a solution. And I think that's what Momnibus Act really looks at, is putting all of those best practices, important need of the time, need of the hour together, because the end result is about saving lives. I mean, for every 700 or so who are pregnant, we have this what you term SMM, which is really, I say it's the tip of the iceberg of the deaths, and beneath that tip is the entire iceberg, which is about 50,000 women that go through near-death experience each year, year after year during childbirth. So how do we address not just the deaths, not just the racism aspect, quality of care, access to care, but also really all of those who come in interaction and, again, go back to this concept of pregnancy, childbirth, is how we look upon civilizations. And it's time for us to really look at ourselves and see what policy change, legislative change needs to happen in order to go from one of the worst performing nations to one of the best performing nations. Science is out there, practice aspects and data is out there. It's a question of acting on it.
I like what you're saying, Dr. Gupta, and I really like where you're ending up. It's putting the focus back on humanity and healthcare delivery. And when I think of everything that you said, I also think that it's so important for us to remember to listen to and hear the voices of women and of mothers to make sure that we truly understand what their needs are, where the gaps are, and what are the measures that we can put in place? What are the programs that we can put in place that address those goals? And we go about doing that in a way that is comprehensive, that gets down to where the mother is or that patient is and really meets them where they are. So when I think about what can we do, that's what we can do. We can really demonstrate that humanity, that empathy and compassion in action.
I think I'm just going to be an echoer. I think that everyone has spoken to the fact that this is a multifaceted problem with many solutions that need to be implemented at the community level. But the Momnibus has all the elements of the ecosystem of care that we're talking about. So although we recognize that legislative processes can take time and may have to work through a variety of issues, we're very supportive not only of this persons of color centered focus, but we recognize that these components that the Momnibus represents really will benefit all birthing persons and families.
Thank you. Yes, we really do want to see the Momnibus put into law. So a question has come in from our audience, a question for Bridget, though others can speak to this as well. Can you speak about examples of healthcare disparities in how care is delivered to people of color and how that impacts outcomes? And you're on mute. Mm-hmm.
Yes, definitely I can. I had to be one of those today, Justine. I mean, there's so many different situations where it shows up, and I can just think of things that I've heard from our own employees, as well as stories that we've seen in the news media. Just recently on 60 Minutes, for example, there was a great news story about African Americans, and we know African Americans, they experience sickle cell anemia. And sickle cell anemia is a condition where you experience extreme pain. And story after story after story of individuals who go into the emergency department or emergency room seeking care and pain relief, they are denied. And the reasons they're often denied is because it's the thinking or the stereotypical thinking that they're in there seeking drugs, not to control their pain, but seeking drugs for other reasons, and they're turned away. If we think about stories that we heard and reflect back on COVID, and we know that in the very early months of the pandemic, when access points were far away, which made it difficult for people in our urban settings, African Americans, Hispanics, Native Americans, to go for testing. But when they were able to get to a testing site, they were often turned away, even though they had presenting symptoms of difficulty breathing, fever, the fatigue. They were told to go home and wait it out and see what happens. And we know that often, and we have stories here locally in Michigan, where these individuals, they went back home and unfortunately they passed away because they were not admitted to the hospital and they did not receive that care. So those are very real things. Or time after time, and there's a great movie that an infant mortality task force has recently shared in our community. It's called Toxic. And it's a very short film, maybe about 25 minutes, of an African American woman, a professional woman who's educated, has a high income, and just the microaggressions and the stressors that she experiences as she goes among her every day during her pregnancy. And this is her second pregnancy. And when she goes in to see her provider, her expressions of concerns were dismissed, and they were dismissed over and over again. And so again, when we think about how it shows up, it often shows up in that way. The Kaiser Family Foundation, and I'm not going to remember the statistic percentage exactly right now. However, it really shows that there is a belief and there is data to back it up that most people, and not just African Americans or other people of color, believe that people of color will experience less care and treatment when they go into a provider setting, whatever that is. So that is a prevailing belief with research out there to back it up. And again, it manifests itself in different ways. So what's key, and we've talked about it today, is just being really able to talk about what being culturally competent and understanding how we need to adapt and understand that what's under that iceberg, and that, you know, one size does not fit all in terms of delivery of healthcare.
Thank you for that. And again, if folks have questions, you can add that to the Q&A. One question, just going back to, I think all of you talked about provider education, or the question is, how are the providers receiving it? And how do you get them to come and join? Are there some that are more hesitant, if you will?
Yeah, I think overwhelmingly, there's a lot of intrigue and interest to really dive deeper in and understand it. I'm not a physician, but I've talked to a lot of physicians, and I'm looking at you, Dr. Gupta and Dr. Smith. But you know, you make that pledge to provide the best care for everyone, and I think that's what's fundamental. But again, it's that opportunity for all of us, in whatever we do, and however we interact with our colleagues or patients or members, to be culturally competent. And so I think it's about that messaging and helping to understand that this is something that we all have to get better at and not doing. It's not an affront. It's that opportunity to just really be more mindful and interact with individuals without judgment, showing that empathy and compassion. And even in my interactions with my OBGYN, she's a white woman, and the experience with her has been very positive because I see her making the connection with me as the person that I am. And so it's those steps that we have to take in our provider settings, as well as in our interactions with one another in general. So I think that messaging is very important. in how well it's accepted by physicians and providers.
Yeah, and I'll add to it. I think very well said, Bridget. I will just add to it that, we see typically that people not only well receive it, but they're hungry for more. And they're asking for, okay, what's the IBT or the Intensive Bias Training 2.0? What's the next thing? Because we all know, I mean, let's not fool ourselves. A 4-hour training in our lifetime is going to change our behavior. So the question really becomes is, how can we change the culture under which we behave in order to translate that into changing behavior? And that's a struggle. We're just touching the very superficial top layer of this problem. But what we can't afford to do clearly is have people who take this training electively and those who have certain views and they elect not to, because it only creates the the polarization and two sides, and that's exactly what we don't want. So I think one of the things that's going to need to happen is we have to have a culture around understanding bias, a culture around understanding, and that starts in a society all the way when you're born, but it also in medicine starts when you enter the medical field. So I think it's going to be important for the medical educational institutions, and this is not all about doctors, because I can tell you, the first time somebody walks in and because the way they look and way they're dressed, and the front office person says, well, honey, give me your license and your Medicaid card, that's where it starts. That's where it begins oftentimes. So this is not about only providers, and it's like HIPAA. This is the HIPAA of the 21st century. You have to think about it. Anyone who comes in touch with an individual who's a patient, you have to make sure the person understands and recognizes their own biases and learns how to manage those. So it's not just for providers, it's for everyone who comes in contact with a patient, because those relationships are made or broken sometimes at the front desk. Mm-hmm. It's not to pick out a person at the front desk, we're just saying. So it's important that we start to begin a process that begins to, again, initiates a culture change in the entire healthcare system, and not just the top layer cover.
The last question, and I know we're almost out of time, so maybe real quick, but it's around value-based care. And how can the movement towards value-based care help with health equities? I know at Blue Cross Blue Shield, we have Blue Distinction Centers, including one in maternity, really helping people get to the highest quality care, which often results in less cost. So real quick, and maybe next 2 minutes, how can we move to more value-based care to address health equities?
Well, actually, our unconscious bias education program is part of our physician group incentive program, which focuses on value-based care. And so we were very glad to be able to offer it as part of that. So it kind of becomes a requirement, but it's also an opportunity, again, to take those first steps in terms of putting that focus on how bias can play into healthcare delivery. And again, looking at it from a positive aspect in terms of the difference that it can make in terms of the high quality of care that we want to deliver.
Well, we're just at about time. Dr. Smith, was there something you wanted to add on?
No, I see the clock, and so I'll let you proceed. I hope there'll be opportunities to answer more questions. And I'm sure you're going to let our audience know that they can send questions that we can engage with them even after this webinar.
Absolutely. Well, I just want to thank everyone for joining us. As you can tell, we are passionate about addressing maternal health in communities of color and addressing health equities. So thank you for being here with us today, and we look forward to continuing to partner with you. And thank you to our panel. You were wonderful.
Great. Thank you for the opportunity.
Thank you.
Bye, everyone.
All right.